Hi, today I'm gonna discuss with you about thyroid cancer. We have a 60-year-old woman is referred to our clinic with chief complaint of neck mass and hoarse voice. The lump is located in the lower anterior neck at the rack of the midline. The mass moves along with her swelling. She denies any difficulty snoring, pain, or exposure to ionizing radiations. Our lab find that she has a high level of thyroid stimulating hormone and under our ultrasound, we find there's a circle well demarcated 2 centimeter nodules in the right tube of thyroid and normal cervical lymph node. So at this stage, we cannot say this is a cancer, but also combined with the age of this patient, we highly suspicious of a thyroid cancer, but we cannot definitely diagnose it before any result of the study. So I'm gonna talk about each type of the thyroid cancer one by one. We have a papillary thyroid cancer. This is the most common thyroid cancer, contribute of 80%. And then there is this a relatively good thyroid cancer because it have a slow progressions, and it's gonna spread to the regional lymph node, and then it's diagnosed by fine needle aspirations. And we also have follicular thyroid cancer. This is composed of 10 to 20% of the total thyroid cancer. And they also have a very good prognosis. And then it spread hematogenously to distant site, most commonly bone. So during the physical examination, if you find there is a lymph, lymph node involvement, then you can think of others like papillary but not follicular. But instead, if you find perform like nuclear imaging and you find this metastasis, then you may suspect of this is a follicular. But there's one thing very critical about this type of thyroid cancer is this cannot be diagnosed by fine needle explorations or frozen sections because this is like very difficult or almost impossible for you to distinguish them between the follicular carcinoma or adenoma. So there's only way that you have to perform a surgery, a lobotomy, and then you send the permanent sections and then to the lab, and then you can diagnose this as a carcinoma or adenoma. And yeah, so there's also a subtype under this follicular thyroid cancer is Hurchel cell carcinoma, and this carcinoma is um is around like 3 to 10%, and this is a well differentiated viral cancer, and they may observe in Hashimoto thyroiditis or Graves' disease. And then, so if your patient have such medical history, then you may raise your suspicions of this type of viral cancer. And then we have medullary thyroid cancer, and this is very well known in another disease, which is multiple endocrine neoplasm. So whenever you find there is MTC in a patient, then you have to make sure you ask about the family history, and then you check for the gene, look for RET gene, and then check for other symptoms that find in men 2A, 2B, such as pheochromocytoma, like gonna be a refractory hypertension, sweating, etc. Or that in 2A there's gonna be others such as hyperparathyroidism, or in 2B, you may also look for some marfanoid hepatitis or um, multiple neuritis, or also like in 2A, find pheochromocytoma. So anyway, if you confirm the patient have MTC, then you must order other tests to exclude men 2A and 2B. And then this so This cancer is gonna usually spread to the regional lymph nodes, and then also have a medullary liver metastasis, and then also produce calcitonin. So this is also one specific part of this cancer. So you may also order tests to look for any increased serum level of calcitonin. And by the way, this is produced by perifollicular C cells. And we also have others type of thyroid cancer, such as B-cell lymphoma, and this is usually developed in the setting of Hashimoto thyroiditis. And then we also have anaplastic carcinoma, and this is a liver cancer with a very poor prognosis, and we have only survival for 6 months. And then there also can be other primary cancer that spread to thyroid. It is very rare, but this also can happen. So if that's so, it's the number one, like most commonly, is by the renal cell carcinoma. For the test we order specifically for thyroid cancer, like I'm not gonna discuss those ordinary lab tests, but those special tests or like those tests we have to order, there's gonna be a TSH level and a bedside ultrasound performed by a surgeon. Why is specifically performed by a surgeon? Because like if it's not undergo by a skillful surgeon, then there's a high chance of falsely positive or negative diagnosis. So we better hand this job to them. And then a fine needle aspiration, but just like I mentioned before, follicular thyroid cancer is not suitable for this method. And then make sure you obtain family history if needed in the case of the MTC. So make sure you don't miss it. And some people might think of we can also order a radioactive iodine, but it's rarely used these days and it's already replaced by fine needle aspirations. And because some cancer, then um, radioactive iodine is not working on them, such as MTC and aplastic thyroid cancer and lymphoma, because they are like poorly differentiated or undifferentiated cell, so they don't express TSH receptor, they don't concentrate iodine, and they don't produce thyroglobulins. So what important is they don't concentrate iodine. So it's there's no point for you to order such tests, and then fine needle aspiration is better for the diagnosis. And then what is the surgical decision for each cancer? Firstly, under the ultrasound, if you find the size is smaller than 1 centimeters, then there's no suspicious features, like there's no, like the margin is not irregular, and this is not like a mixed echo and then etc., then you can just observe the patient. But if the size is large, it's not definite, but if the size is like larger than 4 centimeters, then that is a very high chance of malignancy. So size is also one of the tool we can use to look at, but this is not definite. But just keep in your mind, this is also a good measurement. And then we undergo fine needle aspirations. So if we find, according to each result, if you find there's suspicious for malignancy, we undergo total thyroidectomy. And then if there's um, follicular neoplasm or suspicious for follicular neoplasm. At this stage, just like I mentioned, we are not sure that it's a carcinoma or adenoma, so we undergo a diagnostic nephrectomy, and then we just send the permanent sections for a test, and then if we confirm there is a capsular or vascular invasion, then we just proceed to total thyroidectomy. Or if, yeah, and if that's not, then you can just perform the nephrectomy. And if that's confirmed malignancy, then there's no doubt we can prepare for the total thyroidectomy with central neck dissections. And there's controversy of if central neck dissection is a routine procedure or not, because some said that there's the risk of the damage to the nerve nearby. That is the recurrent laryngeal nerve or superior laryngeal nerve. But some say that because this is difficult for you to perform the surgery again, and this also lower the risk of the recurrent thyroid cancer. So some will choose to perform this as a routine. Both sides are correct. So at the end of the day, it depends on the surgeon and for the best benefit of the patient. And also, like this complications rates like of the damage to nerves really depends on the center and the skill of the surgeon. So it really depends on the center. And then we have a typical of unknown significance or follicular lesions of unknown significance. Then if this come up to be this result, we have to repeat the fine needle aspiration within 6 months. And if that's benign, then we can just observe. And if there's non-digestic, and sorry, you have to do the fine needle aspiration again, try it again, and make sure performed by another skillful colleague, unfortunately. And then, yeah, just like discussed before, should we perform the central or lateral neck dissection? So, like, even though there's controversy, but central neck dissection is almost a routine for MTC, but lateral neck dissection is still under discussion of whether to be a routine or not. But there's the indication of have to do this is if you find a jugular lymph node chain, like a chain of lymph node enlargement that you can feel, you can palpate it, or you find it under ultrasound, then there's no doubt you have to dissect them during the surgery. So for the post-operative management, there's radioactive iodine ablations. This can reduce the chance of recurrence. And then we also have suppressive thyroxine therapy. And this is by suppress the TSH, to avoid the thyroid tissue to grow again. For the follow-up, we perform the thyroglobulin levels and the anti-thyroglobulin antibodies levels for every 6 to 12 months. And mostly the thyroglobulin is this cell is to store the T3 and T4. So if there is an increase of this level, even though after thyroidectomy, so it means there's tissue left and they grow again. So this is a bad sign. And then it means recurrence. And then for each year, we undergo a neck ultrasound. And if this is a case of medullary thyroid cancer, then we also check for the serum calcitonin. The complications I mentioned before, so if there's high chance, I mean, not high chance, but there's a chance of damage to a recurrent laryngeal nerve, which is located here. So, for the reason, by the way, for the reason why, if there's a mass moving up and down with your swelling, then you can identify this is highly a chance of a thyroid mass, because there is a various ligament attached the thyroid to the trachea. So with the movement of like doing swirling, so it moves with the tube, and then so the thyroid gland and the mass in it or on it also move along with it, so you know there's a thyroid nodules. But if it doesn't move, then it's it's rather not a thyroid mass, or there's a worse scenario that is a malignancy, because it grows so large and so intact into the gland. So it kind of like, imagine it attached to it, so it doesn't move along with swelling, so it's a bad sign. And for each nerve damage, they have their unique symptoms. For the recurrent laryngeal nerve, there's gonna be a hoarseness sense, and for the superior laryngeal nerve, the patient cannot make a high pitched voice. Why makes them like different from each other? Because like the recurrent laryngeal nerve in charge of the most of the the larynx muscle, but except thyroid muscle, and the thyroid muscle here is innervated by the superior laryngeal nerve. Here, this is the external branch of this nerve. So that makes those symptoms different. Then you know which nerve is damaged during the surgery. And there's some always, not always, but like possible to be missed after the surgery is hypocalcemia. So that's gonna be by the damage to the peripheral gland. Some may miss it, but nowadays people already give calcium to the patient after surgery like a prophylaxis, so to like just treat it like before it's happening. So I think this is a relatively lower chance these days. So people we just give we but there's still like we give a oral supplement, oral calcium supplement, so you might see you might still find a hypocalcemia because there's a delay action of the oral calcium, but it's okay for you to find that. But if this persists, then you may think of this renal damage to the peripheral gland. And one of the dangerous complication is hematoma. Usually the patient will show up like suddenly shortness of breath, and then like hoarse voice, like you can hear it like clearly. You can just hear it. The voice of the breathing of the patient is like something pressing up the trachea. Then that's very, and then you find there's a mass of it, and then it's erythema, there's redness, then you know there's a neck hematoma, and then you have to perform a bedside incisions and then transfer it back to the theater ASAP, and then let the surgeon to handle it. So this is the end of my sharing, and this video is mostly in the perspective of surgery, so not in the internal medicine. And yeah, and thank you for your listening.